Welcome to The Explainer. Today, we're unpacking the absolute bedrock of medical billing and coding, and we're going to give you the exact blueprint you need to really succeed as a professional in this field. Whether you're just dipping your toes in for the first time, or you're looking to solidify that foundational knowledge, we've designed this session to make the complexities of the revenue cycle crystal clear.
Here's our game plan for today. We're going to look at the compliance rule makers, decode some medical terminology, distinguish illness versus disease, master E&M codes, navigate hospital visit levels, and finally, wrap it up with the rules of bundling modifiers. Let's jump right in.
Section 1. The Compliance Rule Makers. Who governs healthcare coding? To start things off, we really have to understand the environment we operate in, right? The stakes for compliance are incredibly high. So before you even think about assigning a single code, you need to know who's looking over your shoulder. Who actually writes the rules that dictate how we process these claims? Because when we talk about compliance, we're talking about operating within a super strict set of guidelines that are specifically intended to stop fraud and abuse.
Think of this as a strict regulatory hierarchy. First up, you have CMS, the Centers for Medicare and Medicaid Services, which administers healthcare access to millions. Then there's the OIG, the Office of Inspector General. They're essentially the watchdog, safeguarding the Department of Health and Human Services activities. Next is HIPAA, which establishes the absolute national standard for how we protect and handle patient privacy. And finally, the AMA, the American Medical Association. They actually hold the copyright to CPT codes and decide exactly what each code denotes. Together, this group sets the rigid boundaries for your daily work as a coder.
Moving on to Section 2, Decoding Medical Terminology, the language of healthcare.
Now that we know who makes the rules, let's see how we actually translate the condition of the human body into codable language. As a coder, you've got to meticulously differentiate between acute and chronic injuries because this status directly dictates the treatment administered and ultimately the code you assign. An acute injury is sudden, right? The damage just happened, and the tissue is still capable of survival. A chronic injury, however, develops over time. It could be from natural aging, continued usage, or even an old wound that only partially healed.
Now here's a highly actionable pro tip for you. Always examine the physician's report for specific keywords if you're ever doubtful about the injury's timeline. Patients aren't always clear about when a problem started, and you shouldn't just automatically assume an injury is acute because of a recent incident. If you see a word like pathological in the chart, that's your giant flashing neon sign pointing toward a chronic disease process rather than acute harm.
All right, Section 3, Illness versus Disease. And spoiler alert, they are not as identical as you might think.
Let's drill down into some foundational terms that sound exactly the same to the average person, but mean completely different things in our world of diagnostic coding. It is entirely possible for a patient to have symptoms of an illness but not be sick with a disease, and vice versa. An illness is really a state of mind or body. Think about catching the flu. You have an ailment, you feel totally terrible, but it's not necessarily a permanent alteration of your body's structure. A disease, on the flip side, is a fundamental variation from normal bodily operation. Take type 2 diabetes, for instance. A patient can have this disease process occurring in their body without actively feeling sick on any given day. Nailing this distinction is absolutely key to proving medical necessity.
Section 4. Mastering E&M codes. Evaluation and management.
Let's shift our focus to E&M codes because these are by far the most frequently billed codes you're going to encounter in your career. Almost every non-invasive interaction between a doctor and a patient requires an E&M code, but the setting and the patient type, they matter immensely. Notice the difference between a newly registered patient at a clinic versus a returning patient at a doctor's office. A brand new patient requires way more of the attending physician's time for history and examination, and because of that, those E&M codes usually pay out at a higher rate. You've also got separate, specific E&M codes for the ER and for patients held in observation, where they aren't fully admitted but they're being closely monitored for a night or two.
In a lot of practices, you're going to be working heavily with super bills. Think of these as a coding shortcut. It's basically a sheet with the most frequent diagnoses and procedures where the physician simply ticks boxes during the encounter. But here is where you come in. It is your absolute duty to double-check those ticked boxes. You have to cross-reference them against the patient's documented medical history to ensure the stated diagnosis fully justifies the medical necessity of whatever treatment is being billed. You can't just blindly enter check boxes, guys.
Section 5. Navigating hospital visit levels. Escalating patient severity. Now, let's move out of the clinic and into the hospital setting.
Improper coding of physician visits in a hospital can very quickly trigger an unwanted payer audit, so we really need to understand how these visit levels escalate. Hospital visit codes reflect the severity and complexity of the patient's condition. We start with level 1, which is essentially the best-case scenario. The patient is recuperating exactly as expected. The doctor does a routine exam, reviews the chart, makes moderate decisions to move the patient to the next stage of recovery. It's a short, straightforward visit.
But what if things stall? Level 2 escalates the severity, indicating the patient just isn't getting better. The initial approach isn't working, meaning the doctor has to intervene further. They have to consult on new treatment choices, give entirely new instructions to the nursing staff, and probably order more testing. This takes way more time and requires higher medical decision-making.
And this brings us to level 3, the absolute most severe standard E&M category. This is for patients who are deteriorating rapidly despite treatment. This level demands a significant chunk of the physician's time, highly complex decision-making, and reflects a starkly higher risk of patient mortality. As a coder, you have to ensure the documentation reflects this intense volume of data analysis and risk to actually justify billing a level 3 code.
Sometimes, a patient's health is extremely poor, and standard E&M codes might not even cut it. In those instances, you move to critical care codes. Now, the crucial point here is that while critical care codes offer high compensation because they are time-based, they absolutely require rock-solid documentation from the provider. If the paperwork doesn't meticulously support the time spent and the critical nature of the care, you have to default back to the highest applicable standard E&M code. No exceptions.
Finally, Section 6, Rules of Bundling Modifiers, Avoiding Coding Edits and Errors. Let's explore how we bring all this together and avoid those dreaded bundling mistakes that lead to undercoding and lost revenue for your practice. Getting this right requires a specific 3-step sequence. First, the doctor has to properly and precisely record the details. Second, you, the coder, assign the exact CPT code based purely on that paperwork. And third, and this is where the real skill lies, you check if multiple operations are incidental to one another. Lots of times, lesser procedures are bundled into a major, more complex procedure. By following these 3 steps sequentially, you ensure procedures aren't erroneously unbundled, keeping you compliant and safeguarding the revenue cycle.
But what happens when a procedure doesn't perfectly fit the standard description? That is exactly when we turn to modifiers. When procedures deviate, we use modifiers to enlighten the payer. Kind of think of them as a special key that overrides published National Correct Coding Initiative edits. They communicate that a procedure was altered, or that an ordinarily bundled procedure was totally necessary and distinct in this specific instance. Perhaps the best example of this is Modifier 59. The source text literally refers to it as a magical modifier. When you use it correctly, Modifier 59 allows you to legally and properly bill for a procedure that the software would normally bundle away and reject. It's basically telling the payer, yes, I know this is usually included in the main surgery, but in this specific patient encounter, it justifies independent consideration and separate payment. Honestly, it leaves you wondering how much revenue is left on the table simply because a coder didn't know how to properly apply Modifier 59.
From understanding the strict rules of CMS to mastering the magic of Modifier 59, it is incredibly clear that medical coders are the true financial architects of the healthcare system. Without your exact precision, the entire revenue cycle collapses. Are you ready to take control of your coding blueprints? Please like, share, and subscribe to Decode Healthcare with Harshal.